So can you guys all see my screen? You should be able to. It should say Hip Impingement 101. And someone can just type. Okay, perfect. Thank you, Kelsey. All right, sweet. I'm going to try to keep this to an hour or less. And at the end of this chat, we'll leave it open for questions. So if you do have burning questions, feel free to type them in the chat bar and I'll come back to them, or jot them down for yourself and then you can ask them at the end. I'm just going to get through this lecture and then we'll chat at the end. So my name is Dr. Sarah Haran. I run the out-of-network division for ICE, and part of how I got involved in that is that I have my own practice in Seattle, Washington, and a large reason why I was able to start that, it's a cash practice. A large reason behind my being able to get started in that was a big niche that I have in hip impingement. So I do like to talk about hip impingement. It is sort of my baby. So, what we want to talk about today is sort of where PTs land in the management of these patients. So hip impingement is my favorite thing to treat. I think that mostly that comes because I have hip impingement, but also patients actually do really well with physical therapy. And I think, unfortunately, we've seen not great physical therapy. And so if we can be the ones that are giving the correct tools and the right tools for these patients to get better, that we're actually going to lead them in a different direction than surgery. So we're going to talk a lot about that tonight. Okay. So tonight we're going to discuss FAI, so femoral acetabular impingement and labral tears. We're going to examine how FAI and labral tears are managed in many cases, i.e. not with physical therapy. We're going to learn strategies for how we can indeed manage these individuals in rehab, and then we're going to look at how this became my specialty. So again, thinking about niches, we'll spend a little bit of time on that. I can't help it because that's the portion of this that I am involved with. Okay, so first off, a little anatomy. You guys are probably pretty familiar with this stuff, but I want to just briefly go over it. So femoroacetabular impingement can be labeled in a couple different ways. Many people will come into your clinic and they will be showing you their imaging, and it will be very concerning to them. They will know if they have pincer or cam impingement or combined. And so it's important that we know what these terms mean. So pincer impingement is when there's extra bone extending out over the normal rim of the acetabulum. So it's presumed that the femoral head then kind of bangs up against the rim sooner in the range of motion. And so that can in turn cause quote unquote impingement. Okay, cam impingement is where the femoral head is more oval or egg shaped. And again, it's presumed that then the head cannot rotate smoothly inside the acetabulum. I'm saying the word presumed because we're going to come back in and talk about that, but this is how the patient will understand this because this is what their healthcare providers are usually saying to them. Combined impingement is where both cam and pincer impingement are present. And then functional impingement is a term that I use to describe when a person who has normal bone shapes, quote unquote normal, actually presents with the same symptoms of impingement. And usually we see that that's because of muscle imbalances, abnormal movement mechanics. Sometimes it can be a loading issue, too much loading, not enough loading. But they're presenting like a hip impingement patient without that bony, quote unquote, abnormality. Okay, so here's a picture of kind of what we're looking at when we're talking about these different types of impingement. Okay, so when it comes to labral tears, what we're talking about is the femoroacetabular or hip labrum. Okay, it is a ring of cartilage that lines the ball and socket of the hip joint, and it's thinner on the anterior aspect. So that's important to note because typically that's where the pain is. Most of the time, that's where the tear is, if there is a tear. The labrum gives the hip stability. It also protects the articular surfaces of the joint, okay? The really important pieces to remember and that I think are important to educate our patients about are that the labrum provides proprioception and it is a negative pressure environment. So it sort of helps with that centering idea of the ball in the socket. Causes of labral tears. Typically, we're going to see direct trauma, like a motor vehicle accident. We see this a lot in the NFL. We'll see players essentially like running out of their hip, falling with or without a hip dislocation. We can see this a lot in sporting activities that require certain amounts of external rotation or hyperextension. I see this a lot in soccer and hockey. We definitely see it with our dancers. Specific movements including torsional or twisting movements, hyperextension, hyperabduction, external rotation. Improper technique with repetitive activities, right? So if we're kind of going into the same position over and over, and then essentially higher excessive volume of activities will be giving us that same issue. Okay. So, although it will be cam or pincer impingement and or a labral tear that show up on imaging, it's often going to be the muscle imbalances, suboptimal motor patterns, and poor load management that lead to most of the problems surrounding FAI. So I want to be clear that a traumatic labral tear, which is not a consequence of overuse or chronic FAI, is not really what we're talking about here. We are talking more about the chronic FAI patient. Traumatic labral tears can actually respond pretty well to surgery. And I think that that's probably true in the shoulder as well. When we're talking about chronic motor patterns or load management issues, we're looking at physical therapy usually. So, as it says at the bottom of this slide, this is going to require a program consisting of education, strengthening, functional training, and typically not surgery. So again, as we're talking about FAI and as we're talking about labral tears, I am referring to this particular type of patient that's a little bit more chronic and probably developed these symptoms over a long period of time versus somebody who had a pretty aggressive tackle in a football game and then tore their labrum. Okay. So symptoms that we see. In the early stages of this condition, patients sometimes aren't aware that anything serious is going on. There may be kind of inconsistent symptoms, or the symptoms are really mild or vague. I've had cases where people will schedule with me, and maybe they're scheduled for a couple of weeks away, and then they'll cancel it and send me an email and be like, I don't know, my hip isn't really hurting anymore, so I don't really know what's going on. And by the time I actually see these people, sometimes they're like, yeah, I just kind of feel crazy because sometimes I have pain, sometimes I don't. I can't really reproduce it all the time. I'm not sure. And that is really pretty classic of these patients, that it can be a little bit unclear and it takes a long time for them sometimes to come in for help. So typical symptoms listed here: stiffness in the thigh, groin, or hip. Can see a loss of range of motion, although many of these folks are hypermobile. So loss of range of motion may just be a loss of their range of motion. Deep aching in the groin or buttock. Usually that's the biggest key, is it's kind of a deep, deep ache. Sharp pain in the groin or buttock when the thigh is moved into the scour position. So internal rotation, flexion, adduction. Pain with sitting for long periods of time. Sometimes they'll get that aching pain again. Difficulty with weight bearing, clunking, popping, or clicking. This is a really big one that we'll see sometimes. In particular, that clunk can happen when lowering the leg from a flex position. So with our dancers, that's lowering it from what we would call like a développé position, where the leg is out in front of them and they're lowering it down. In our CrossFit athletes, we hear about this a lot, and I've experienced this with toe to bar or V-ups, things like that. So if they're giving you that kind of clue, key into that. Pain at rest and or with activity, definitely pain with their sport, pain during or after sexual activity. Sometimes that's just positional pain, but oftentimes it can be pelvic floor because the pelvic floor might be tight. With these patients, low back pain or SI joint pain and knee pain can definitely show up. So when we are talking about functional hip impingement, this is where, again, we're not really sure that they have a bony abnormality, and we don't really need to focus on that. And so we try not to, right? And even with our bony impingement people, I try to meet them where they're at and go through their imaging with them, but I try not to breathe too much life into it, right? And I over time will educate them about the importance or non-importance of that stuff, but up front, I think it's good to discuss with them. Okay, so again, functional hip impingement. Pain typically occurs in the anterior structures of the hip. This is kind of the key takeaway that I want to talk about tonight. Things to think about. There is a lot of debate regarding the relationship between biomechanics, posture, and pain. I am a therapist who was trained in manual therapy and a lot of biomechanics as I developed my practice. And so I do have a bias, and I recognize that bias. It is there. So I am a little bit more biomechanical. Now, I'm also aware of all the research that's come out, and that pain is very complicated, right? So you can kind of take all of this with a grain of salt, but the idea here is that there are pieces of the puzzle that can be addressed in PT, and these patients may not need surgery. So we'll often see a pattern of overactive TFL and an underactive glute, and often abdominals as well. We will see a tendency to self-treat with distraction mobilization. So a lot of like banded on the rig, lateral distractions, or anterior glide. I'll see a ton of stretching into hip extension. I wrote hip extension stretches. What I mean is into extension, they're stretching their hip flexors and a lot of psoas release. And then we'll see an avoidance actually of impact activities like running, jumping, hiking, and weightlifting because of the thought that that might cause more of a problem. So the big picture here is that with impingement, a patient can most certainly have bony anatomy that points toward true FAI, quote unquote, but they might not. And that's why we call this functional impingement. And oftentimes we see a patient who feels particularly hopeless because, in fact, nothing has shown up on imaging, right? And then nobody knows what to do with them since surgery isn't indicated and previous PT isn't helping. And so we see all these patterns here where they have all these muscle imbalances, and then they're kind of self-treating or avoiding certain things. So this is where we can come in. So as physical therapists, are we guilty of further stretching into these positions because they feel restricted to the patient and the muscles are palpably tight or stiff to us? I want to make the argument that biomechanics and posture aren't, of course, the only main culprit behind a patient's pain, but that we often see these patients kind of live in hyperextension and external rotation. They tend toward those positions. And I don't know if that's because I treat a lot of dancers, and dancers tend to have this condition. And is it a sports selection issue? That's a whole nother topic for another day. But oftentimes we are seeing these patterns of hip hyperextension and usually a lot of external rotation. So stretching the anterior structures is not ideal. And that is often what I will see when a patient comes in and they've quote unquote failed physical therapy. So it's really hard to change a paradigm, right? Whether that's how we treat a diagnosis or how we work with insurance. But many patients with FAI are told to avoid physical therapy because of this, because a lot of times it makes their symptoms worse. I think that what that is indicating is that PTs are trying to increase range of motion, either despite the structural limitation, that bony impingement, or they're kind of missing the boat and that there's compensations, muscle imbalance, tissue inflammation and irritation and spasticity, or a combination of all of that, right? They've got all this tone, and so we're trying to decrease that tone, but maybe we're just pissing things off more. So we do see a lot that people are saying, well, my doctor told me not to come to physical therapy. So the bottom line is that there's a victim, a bully, and an outcome. And we see that in all of our treatment, right? The painful structures, the victim, of course, needs to be addressed. But sometimes that's the hip flexor, right? And that doesn't mean that that is the problem. The origin of the issue needs to be addressed. I call that the bully in the clinic. And then the compensations or the outcome need to be addressed. So the big question is surgery the only way to correct this? So how are these patients being managed? Okay, this theory has been around since the 1930s, and this like blows my mind. That's 100 years ago, 90 years ago, okay? The conventional medical theory is that the quote unquote abnormal bone shapes lead to labral tears, arthritis, pain, and immobility. Surgery is supposed to be the only answer. Now, though I never was a big proponent of surgery for these types of patients, I did subscribe to the theory that abnormal bone shapes and thus the quote unquote banging around and early bony contact in range of motion led to these things. And I would tell my patients that. And I've really gotten away from that. But you're going to hear it, and you're going to hear patients say it, and you're going to hear surgeons say it. So if that is the case, then surgery would be the only answer, right? But the literature does not support this. So why are we still thinking and treating based on this theory? That is the question. I want to address some reasons why we're still thinking and treating this way here. In many cases, these patients are being sent from their primary care doctor. So they go in with hip pain, general pain. The doctor sends them to an orthopedic surgeon, and imaging is ordered. If these anatomical variances are found, then we go down this rabbit hole. Maybe it's a Google rabbit hole, or maybe it's a healthcare system rabbit hole. Unfortunately, many patients and practitioners are going to see this diagnosis on X-ray and immediately assume that surgery is the best answer. A lot of times, nothing shows up on X-ray, and so then they're going down the MRI route. And again, a lot of times things don't show up, but they still present with quote unquote impingement. And then that's when the frustration really starts, because they've got this functional impingement that nobody knows what to do with them. So if they have imaging that shows anything, sometimes surgery is necessary. I will not say that surgery is always bad, right? It can be helpful, but for many of these surgeries do not relieve as much pain as they expected. And in some cases, it can make the pain worse. So to be clear, it's not that they are not getting any benefit from it, but maybe it wasn't as good of an outcome as they thought, and maybe it's not any better than physical therapy. And finally, surgery cannot correct poor motor patterning and weakness. So without proper and extensive rehab following surgery, these problems will persist. So they're going to have PT anyway, hopefully, and hopefully we can catch them before surgery. So this topic of over-surgerization is really coming to light in the last about 2 years. There's evidence to point to the fact that these surgeries are on the rise. It's not because people need them, but I think that one of the most important reasons here is that they're now covered by insurance. So when I was going through discovering that I had hip impingement and a labral tear on both hips, and I was like adamant that I needed surgery because everybody else was telling me that, it wasn't covered by my insurance. And the silver lining is that I didn't have surgery because I couldn't afford it. And I had to figure out how to help myself. And now I have some tools that help hip impingement patients. Additionally, surgeries are on the rise because more and more doctors are being trained in the procedure, and more radiological imaging is being done to diagnose the issue. So, of note, obviously, there are many surgeries we used to do that we now see were unnecessary and or harmful, and this needs to be considered. We do not have a lot of long-term data to support any outcome for this type of surgery because it's only been, around for about 20 years. All right, buckle up for some alarming statistics. Surgery performance rate for FAI syndrome increased 18-fold over a span of 10 years. Now, this is data from 2009, so I would assume that the growth is much higher than that now. But Dr. Mike Ryman, I'm sure some of you guys have followed his work on hip impingement. he noted that 600% of that new growth, or that growth, was from new surgeons. So this is very problematic and very troubling. I think these things, to put numbers on them, it just really blows your wig back. So, important keys here. We need to draw attention to these truths. The bone shapes involved in FAI are normal anatomical variants. They are not necessarily problematic. So it's a good reminder that we do not need to pathologize everything that shows up on imaging. We know that, but it's just a really good reminder. The arthritis question. So the research is not conclusively showing that CAM and pincer impingement lead to arthritis. So we need to stop saying that to our patients. We have no long-term data to support that a surgery would be protective against that possibility. So again, it's been long proposed that living with bad bony anatomy would lead to arthritis, okay? But the surgeries have only become more and more prevalent probably in the last 10 years. So they've been around about 20, but really more common in the last 10. So we don't actually have any long-term outcomes to even compare. So for a surgeon to say, well, this will happen, we don't know that to be true. So I think that's fair to say to your patients that we don't actually know that that's going to happen. And I would argue that surgery is a pretty big trauma to your system. So who knows what that's going to do down the road. All right, finally, pain is complicated. Labral tears and other joint pathologies are not always linked to hip pain. So again, I think a lot of times it's incorrect movement patterns that can contribute to pain, especially in the patients who are presenting from like a dance background or even CrossFit, where they're doing repetitive movements in the same way and not balancing the joint on both sides, or maybe their movement pattern could be more efficient and a little less painful, right? However, I will recognize pain science is demonstrating that the pain experience is more complex than we ever realized. So I think it all matters and pain is complicated. So we just need to remember that having a surgery isn't necessarily going to help us. Okay, 34% of patients stated that they knew they wanted surgery for their FAI. So they knew they wanted it. 21% of them were not even willing to try conservative therapy. And I've had those situations where I'll see a patient for one visit and then they do well and we make a plan, and then like 2 days later they cancel all their appointments. I reach out and they say, oh, I just decided I'm going to have the surgery. I don't want to deal with this. Well, to me, that suggests that patients have a propensity for overconfidence in surgery as the gold standard. They also have an over-reliance on imperfect imaging findings, right? And flawed information sources like Google or the Facebook group for FAI. It is quite possible that healthcare providers also have a propensity for this overconfidence, right? So I know that in my earlier years as a practitioner, I trusted the surgeons more than I trusted myself. And that is not to say that surgeons don't know what they're doing. They obviously have the best interest of the patient in mind, and surgery is just their tool, where my tool is physical therapy. But to place all that weight and all that confidence in one facet of this is irresponsible. So we need to really get over that and trust ourselves to be providers of choice for this group of people. Because surgery for FAI often fails to meet the expectations of patients, and it's rare that a patient returns to their prior level of function. Okay, so they may return to the sport, and I think that's one of the arguments that I've heard people making recently, but it's pretty rare that they return to their prior level of sport. A lot of my patients who wish to have surgery get really focused on Lady Gaga and all of the football players who return successfully. But I will say Lady Gaga is very open about her hip pain. For one, she has fibromyalgia, and there's a big, I think it's on Netflix, a big documentary about that. She's really open about it. So her pain processing might be a little bit different. Also, it's proposed that this happened traumatically in a show when she was dancing. And then many of the football players having surgery, they're having surgery after a traumatic injury and a labral tear. And just because FAI showed up on the imaging doesn't mean that was the culprit, right? So we can't use those examples. Plus, their rehab is going to be way different, right? They're getting rehab 5 times a week or more. So it's just different. Don't think that it's a good comparison for our patients for the most part. Okay. And we see clinically that patients are still having symptoms and or functional limitations a year or more out of surgery. And that is one of the groups of our hip impingement population that we tend to see. So we tend to see people who don't want to have surgery. There's a group of them. There's a group of people who did have surgery and are super frustrated because they feel the same. Maybe they feel worse, but they don't feel better. They don't feel the way that they were kind of told they would feel. So why isn't physical therapy a first round of defense? This is concerning, right? Despite my literature search actually pointing toward positive outcomes for conservative management, PT is not often prescribed for these patients. Unless there's a sports medicine doctor in your area or a GP that really understands this, they're usually sending these folks right to the orthopedist. And then the orthopedist or the surgeon, they are probably going to use their own tool, which is surgery, if they think that's important, unless, again, we educate them and they have a good relationship with you. So going back to what I said earlier, many MDs do not send their patients for physical therapy because sometimes the outcome is no change or worsening pain. So instead, they're going to refer to a surgeon versus PT. Is what's happening that the patient is coming back to the physician and saying, my pain feels the same, PT isn't really working, in fact it's kind of making it worse, and then over time that doctor stops referring to PT and doesn't believe that PT helps, but they don't necessarily know what's happening in PT. Those are some ideas of why maybe we're not seeing these patients come in the door. I think also we could be marketing to these patients more and educating them that we know how to help them. Do we not know how to help? Is that the problem? Are we caught up in the hype of surgery being necessary? So if we do know how to help, are we marketing ourselves? If we don't know how to help, are we seeking out education to figure that out? Or are we just relying on surgery because that's what we're learning or think we're learning to be the best course of action? So why doesn't PT always work? Why doesn't it offer these great results that we need? Okay. Before I go over this slide, let me go back for a second. So I think that usually when we're talking about did PT work or not work, it's important to note that the outcome measures that were used in the studies to indicate that surgery worked over PT usually refer to functional tasks that are a lot lower. So we're not seeing questions like, can you run a marathon at your prior level of function without pain? Or can you back squat 1.5 times your body weight without pain? We're seeing like, can you drive to work? Can you sit in a chair for an hour? So that indicates success in a research study. That's what their outcome parameters were. But all we see in the media or in a social media post would be surgery is effective for this condition, right? But when you ask the patient, like, are you back to your prior level of function? And they say, no, I can't even run down the block, then that's problematic. Okay, so they need us. All right, we want these folks in physical therapy, okay? I think that's the biggest thing. So how do we manage them the best? I'm not going to go over like from A to Z how I treat these patients. We all treat differently. And I think one of the biggest things that we can do is educate them about all of those statistics I just went over, because surgery is really not the best option in many, many cases. So if you guys can get comfortable kind of talking about that and and putting yourself in a position to say, I am the expert and I believe that I am, that in and of itself will be so, so helpful. Because if we're not really sure and we're kind of nervous about this diagnosis, then that patient wants help, right? So if you're not demonstrating that you know how to control this situation and help them with pain, then they're going to move on. They're going to try to get an injection. That's probably not going to work. And then they're going to try to have surgery. So, as I have had success treating hip impingement patients with physical therapy, I feel very strongly about this. And then I was able to build a cash practice largely because of this patient population. I'm just going to kind of go over what I think works the best. And then at the end, I really encourage you guys to ask me questions. I have a bunch of videos in here of treatment exercises that we're not going to go through because this lecture would then take 2 hours. But you can click on them when the slides are uploaded. You can click on them and they're little YouTube videos. So just so you know, you will have access to that. Okay, so in our assessment, well, first of all, let's talk about this. So it's really, really important that you connect with that patient right away, right? So they're going to come in waving their imaging all around, right? Or maybe they've tried PT and they're frustrated. They've spent money, they've spent time, they're not feeling better. Okay, so we need to sit down with them, look them in the eye, and make them feel comfortable for a minute that you have control of this situation, right? Connecting with our patients is huge. Connecting with people in general is like a huge purpose of why we're on this earth, right? So connect with them, listen to them, do not interrupt and immediately tell them that surgery is a bad idea. Meet them where they're at, okay? When you're going into your assessment, of course, you do want to rule out lumbar or SI joint drivers. Like I said, they're often going to come in with imaging, so you can go over that. I think it's important to demonstrate that you understand what that imaging is, like you understand what cam impingement means, for example. Again, you're going to see a pattern with symptoms. So, for example, because we see a lot of CrossFit athletes and dancers, one pattern that we see is excessive hip opening. I think it's pretty cultural in these patients that that's what they're doing. You would think just dancers, but I see CrossFitters constantly doing hip opening. And so they're positioning themselves into extension and external rotation. And again, I don't want to go into biomechanics, but if that's the position that they're always doing, it's just kind of, it's overused, right? So you're going to do your normal hip exam, palpating for the anterior femoral position. That's something that I like to do. Because I feel, especially in my skinny little dancers, I can feel that that femoral head is anterior and it's often pretty tender. And usually the posterior structures, so I'm talking like deep external rotators, are pretty restricted and tight. They've achieved adaptive tightness, right? Especially if these folks are positioning themselves into external rotation all the time. I like to do the march test to see how active the hip flexors are. So I'll just have them in supine and in hook lying, and they literally just march one leg up, and I'm palpating right on the TFL, and just kind of it's subjective. How overactive is that hip flexor, and is it different side to side? And they can usually feel it. Manual muscle testing, of course, I think is important. And then in your hip exam, when you're doing range of motion, remember that range of motion of the hip is pretty variable. So they might be trying to increase motion when in fact that limitation is bony. For example, I was a ballerina for 20 years. I have 0 degrees of internal rotation. That made me a good dancer. Okay. But as a clinician, if somebody is looking at my range of motion, they're going to be appalled by my lack of internal rotation, and they might be trying to push me into that position, but it's bony, and that makes me feel worse. So I think, again, going back to, are we making our patients worse? That's something to remember, that a dancer wants a lot of external rotation. A CrossFitter, they probably need a little bit more internal rotation than a dancer because they need to get into that deep squat and they need to get that posterior glide of their femur. So Things to think about there. Okay, treatment. So as I said, the biggest thing is to listen, right? I think that everybody who's involved with ICE is learning really good strategies for evaluation and assessment and treatment. And I really don't see that this is a problem with any of you guys, but I will just gently remind you to listen to them. They are stressed. They are frustrated for sure, and they've gotten the runaround. Usually these patients this is not their first stop. So listen to them. They want to tell their story. It's usually long, it's usually complex, but have a little empathy that that's important to them. It's part of their process. The first thing, and I think also being careful not to undermine other providers. So if they say to me, I've had physical therapy and it didn't work, I don't ask them, where did you have physical therapy? I want to know, and then tell them, oh yeah, I've heard bad things about that place. No, I want to reassure them that every provider that they've seen has their best interest in mind, right? I do believe that that is true. I don't think that any of us mean to hurt our patient or not get them better as quickly as we can, but we just maybe don't have the tools, right? So I want to be really careful not to throw anybody else under the bus, even the surgeons, right? That's their tool and they think that that's going to work. Then I commend that. But educating them about all of those statistics so that they can make a educated decision is important. The first thing I educate them about, and this is like, basically I said to both Beth and Dan when I hired them, if you want to work here, do not stretch the hip flexor. So that's the first thing that we teach them is about stretching. And like we talked about earlier, if you're kind of already living in hyperextension and the tissues are irritated on the anterior aspect of the hip, is that because they're short or are they just pissed off? Okay. I also don't laterally or long axis distract that joint. So if that patient feels unstable, go back to the anatomy. I said the labrum creates it's in a negative pressure environment. So it creates that kind of suction feel. If they have a tear, we've lost some of the integrity of that environment. So they might feel unstable. They might have what some people call it a micro instability. And if they feel that and they're getting a lot of cracking or popping, and then you're like distracting it, it may feel really uncomfortable or unsafe to them. So I try to be careful with that. I will sometimes do like a mobilization with movement into flexion, but I try not to pull on that leg. I also think that it's important not to be too centrally focused on the spine as the driver. So yes, screen it out, but remember this patient has been through the ringer and they are coming to you with hip pain and a lot of things have already been ruled out. Now, does that mean that the thoracolumbar junction might not be involved? No, of course it might be, but especially on the first treatment, I encourage you to look at the hip. So that's what happens a lot in the area that I live in. There's a huge manual therapy focus, which is awesome because I trust that people are getting better. But when I see people who have quote unquote failed physical therapy, often they tell me that all that they've been doing is getting manual therapy on their spine and learning core exercises and learning how to fire their multifidus because that's apparently what the problem is. And that's pretty frustrating to them. So I think, yes, rule the spine out, rule it in, but try to remember that hip impingement is a hip problem. Okay. And then manual therapy, like I said, it mostly consists of soft tissue work or myofascial release to the posterior structures. So that adaptive stiffness is really common right at that posterior aspect of the greater trochanter, right where all those external rotators insert. And then I will do mobilization with movement into hip flexion with those guys. And that usually feels pretty good because usually hip flexion is what's bugging them a lot. Okay, and then the exercises, like I said, I've got a bunch of videos here. These were developed kind of out of my own professional and personal experience. Basically, I was being treated with a lot of stretching and a lot of spine, and I wasn't getting better. And I ended up quitting ballet and working out with a personal trainer. And through getting strong, that's how I got better. And so I learned a lot from that personal trainer about weight training. And then finally, a critical look at the current research, again, indicating that surgery maybe isn't the way to go. So the end result is that I like to focus on restoring motor control, building strength in the glutes and abdominals, and turning down the tightness in the hip flexors and the low back. I usually start with diaphragmatic breathing. I think that that's a really good way to, like I said, turn that tone down. I also want them to understand where their TA is, what it does, and what the obliques do versus a posterior pelvic tilt or tuck. So a lot of times folks with hip impingement, I joke around and tell them that their brain thinks that their hip flexors are abs because those hip flexors are just constantly doing everything for them. And when I tell them to turn their core on, they posteriorly tuck. And that isn't using their abs. And in fact, it's aggravating their hip because it's kind of shoving that femoral head into hyperextension. We like to turn down the TFL activity. So there is a exercise in this list that's called TFL down training. So I would encourage you to click on that. And then as soon as I can, as soon as they get kind of familiar with all these techniques, I get them off the table. We do a lot of hip hinging, we do a lot of squatting, and we load the correct patterns. So we know that the research really points to we need to load our patients. We need to get them strong, but we don't need to encourage loading of the same pattern that got them into this position, right? So especially these chronic folks, this is already a problem for them. So make sure that you're teaching the correct stuff, the most effective and efficient movement patterns for that patient population, for that athlete, and then loading it up. Okay, so as I said, these are all videos, so you guys can click right on those. I'll just kind of pass through them here. So as eccentric, bridging without a posterior tuck, hip hinging, single leg hip hinging, squatting, and kind of some tips for squatting because sometimes these folks really struggle with squatting, but it's important that they do it. Okay, so I want to move into how this can kind of contribute to specialization or niches. So how did this become my specialty? As I said, this really was like my own kind of story led to this, but I will say I think that connection is one of the biggest things that works in my favor. I think that it's one of the most important things a PT can offer a patient offer a patient. It's purely connection. Brene Brown, I'm sure you're all familiar with, states that connection is why we're here. It's what gives purpose and meaning to our lives. And that is a really strong statement. But I get asked a lot, like, how are these patients following you? And like, how did you get this far with this specialty? And really, I think it just comes down to me sitting down and listening to them and letting them share their story. And then I shared my own story. So that was really important to a lot of these folks because they felt like I was connecting with them. I do not think that I am doing anything special with these patients outside of that and maybe thinking outside of the box. Traditional PT of stretching and kind of focusing on a central cause was not working for me. So I had to figure something else out. And as I did, I started to write blog articles. My most popular blog article was literally about myself. So that feels really weird. I will say it took me a long time to put that blog article out because it feels very weird to talk about yourself. But vulnerability and honesty about my experience was way more important to these patients than facts and articles and marketing campaigns about hip impingement. And definitely more important than me kind of bashing surgery publicly. So it was kind of a positive feedback loop. I figured out who my audience was. It was the patient, not the surgeon, and not other PTs. So when you're blogging, it's really hard to put your material out there because it's scary. You're not really sure, like, am I the expert? Like, who am I to be putting this out here? Who's my audience? Am I talking to other PTs? But I would encourage you to connect with your patients. And if you have a specialty that you want to have a specialty, start to write about it and start to connect with these patients about it. And remember that your audience is your patients. So I started to connect with people more, and then that led to all kinds of projects. That's a big reason why I got involved with ICE. Jeff reached out to me and I was on a podcast. It has led to a creation of an ebook, and it actually has led to a lot of virtual appointments because at the bottom of this blog, I wrote, please contact me if you have any questions about your situation. And then basically over time, people were like, how can I see you? So I think that all of that stuff is possible for all of you guys. I will say I wanted to do that for years and didn't really have the time or energy to do it until I owned my own practice, because I just didn't have the time, right? And then that admin time wasn't really available to me in a employment situation. So I do think that specializing can lead you down a path of business ownership if you're interested in that. So again, specialization contributed greatly to being able to start an out-of-network process. I do think that a large part of my success came from having a few specialties that people are willing to spend money on. So I do want to kind of reiterate that. I'm not saying it doesn't work otherwise, but it is important to note that. These specialties did develop organically for me, and I was specializing in these areas before I opened my cash practice. So that's another thing to kind of think about, is that even if you're not ready to start your own business, you can start creating a niche for yourself. And it usually comes naturally because you're naturally drawn to treating something, and then you get good at it. And then people kind of seek you out, and then you get even better at it. So I don't know. I think I will reiterate that because I have something unique, people understand they need to pay for that. They want to see someone who understands their needs. They often have already seen other providers, and at that point, their focus is on getting better. So they don't really care what the cost is. So that is all I have tonight. I hope you do get a chance to go back through those exercises. I apologize for not going through them, but I really didn't want to take up all of your time doing that. But I did want to give you the resource. There are some citations here if you want to look into any of the research that I cited. Otherwise, I will open it up for questions. So why don't I propose a question for you guys? What is sort of your go-to exercise when somebody comes in with hip impingement? Kate, I will answer that in a minute. I would love to know what you guys are kind of focusing on. All right, nobody wants to talk. So Kate asks, on the topic of avoiding hip flexor stretching, will you have your dancers limit hip extension until symptoms improve? This is a really good question because dancers need to go into hip extension, and they go into a lot of it. So what I tell my dancers is when you are auditioning for something, or if you are performing, I want you to go all out and do what you need to do, right? Like be the externally rotated dancer that you are. Try not to live your life like that, right? So I try to get them to avoid things like laying on their belly with both legs in like a butterfly position where they're going into external rotation. That's a really common dancer stretch, and they'll just lay there and do their homework like that for like an hour. So they don't need to do that. They're getting enough of that in class. It is kind of like person to person. I don't necessarily limit hip extension in their sport, but I will say that I try to get them not to do like pigeon pose on top of that. Okay, Nicole asks, are you saying, Nicole, that this is what you give them? Anything that isolates glutes, such as bridges, clams, single leg glute, RDL? I think that's what she's saying. Okay, perfect. She says yes. I really like all of those. I think if you go into the video and watch the bridges, be really, really aware of if they are doing a posterior tuck first. And otherwise, if they are able to just kind of keep their abs on and use their glutes to lift up instead of rolling up like Pilates style. Additionally, with clamshells, I struggle with this exercise with people a lot because it can be very TFL dominated. And so I kind of prefer, I call it the Jane Fonda. So just side lying hip abduction. And I sort of get that leg almost into a little bit of extension behind them. And I'll even internally rotate the foot, the whole leg to isolate a little bit more because I really don't want them using a whole lot more of their external rotators, if that's the kind of person we're looking at. And then Ren says, typically I work on detraining TFL and then work single leg glute. Oops, just lost it. Single leg glute strengthening, hip hikes into a physio ball, side planks, and any single leg stability work. That's great. I will add that dancers, surprisingly, they love working with kettlebells. So that's a really good tool if you can get them doing like a kettlebell deadlift. They're a little more hesitant about a barbell usually, but you can work your way there. But having a good heavy kettlebell like a 35 or a 44 is a great tool because if you can get them hip hinging with that, then they really start to feel their glutes. Okay, Nicole, are there cases where you'll do psoas release on the patients having high irritability anteriorly? I typically don't. I will use a lot more diaphragmatic breathing there to work through that, but I do a lot of deep work through their deep external rotators. I also will do some cupping usually through their QL if that's an area of tightness, but I try to kind of leave the anterior structures alone. You certainly can do some psoas release. I try to discourage my patients from doing self-release. Lately in the CrossFit gym that I coach in, people have bought this tool that's like it looks like a camel's back. It has like 2 humps and they're like laying on it to release their own psoas. And I think it's designed specifically for that and it makes me want to puke. So I don't really know, they're not necessarily my patients and I don't know what their purpose is, but I would not suggest that. I think there's too many organs there and they don't probably need to be doing that. Anything you do when you have a high irritability patient to calm their hip down. Yeah, so when they're really, really irritable, usually they don't want to even extend into neutral. So when you lay them on the table, sometimes they won't even straighten that leg because it's so sore. So I'll definitely put some pillows under their knee and I will calm the tissues down by just sort of doing gentle myofascial, well, not even myofascial release, just kind of like jostling their leg, right? And I kind of go down through the quad and kind of where the IT band and the quad meet. And really, I'm just talking to them. I'm probably just calming their nervous system down, right? My hands are on them. I'm making eye contact. We're chatting and they're starting to feel safer and safer, right? I'll get a little more aggressive with the the posterior structures, but usually that feels really good to them. And then these are the patients who, once you can calm that down a little bit, I do that mobilization with movement into flexion. So I kind of throw their leg up over my shoulder. I'm sitting on the table with them, and I put my hands really, really close, like all the way down into their groin, and I just gently pull into an inferior glide while I'm with my shoulder kind of flexing their hip. That usually feels good. And I'll even kind of I'll stay away from pain. I'm not going into a scour position, but I'm just kind of jostling it and giving them a little bit of confidence that their leg can go into this position without pain. And if you get their muscles to relax, if they're not helping you and it's passive and they don't have pain, then we know it's probably not the joint as much as just the tissues are jamming everything up, right? So if they're overactive in all those hip flexors and I can get them to turn them off and then I can clear that joint, then all we need to do is work on getting that TFL to calm down. So does that make sense, Nicole? Okay, perfect. I don't know, did I miss any other questions? So when you guys are working on down training the TFL, and take a look at that video, like I said, but when you're doing that, oftentimes a patient is like, what am I even doing? This is so stupid, right? So really, you shouldn't have to do it for long if they're good at it, but really reiterate to them, if you cannot do this without the muscle that I'm trying to get you to turn off kicking on, then you have to keep doing this. It is essentially a bicep curl. That's all you're doing. You're holding that strap so that just like the mobilization with movement where they're on my shoulder, I'm getting them to hold all the weight of their leg, and then they're passively moving it through hip flexion with their bicep curl. And if they are like, this is so dumb, and they can't do it, then you just really got to stick to it and get them to be compliant with that one, because that one really does help quite a bit. Okay, any last thoughts, you guys? Yeah, thank you. Thanks for joining tonight. And if you guys do have any questions, feel free to reach out to me directly. I have lots of videos to share, and there are a couple podcast episodes from 2019. I think there's 3 where I go through a couple exercises and a lot of this research that we talked about. So you can look those up on the PT on Ice podcast. And if you have any interest in the hip blogs that I've written, reach out to me and I'll send them to you. They're just on my Aerophysical Therapy website. Okay, all. Well, this is recorded and it will go up on the site as soon as Alan gets to it. And let me know if the videos don't work, but they should. I hope you guys have a good start to 2020.